But right now it gives me a great privilege to introduce our panel, Data Quality and the HEDIS Audit. The moderator is Wendy Talbot, who's the Director of Audits and Data Collection at NCQA. We have Anu Sajja, President of Accurate, Matt Flores, Client Manager, Advent Advisory Group, and Glenn Braden, Principal and CIO of Attest Healthcare Advisors. Give them a round of applause. I'm looking forward to a great panel. Wendy?
Keep thinking that's me, but I think it's chairs moving, so. Good afternoon, everybody. Hopefully you had a great lunch. Thanks for joining us here for this panel session. I do have a few slides that we thought we would go through kind of relatively quickly and really use this time together to hear from the auditors and to allow you to ask questions. So it's really, I'll kick off with a few slides and hand it over to each of them to share some experiences with clinical data, electronic data, kind of what they're seeing from the audit perspective, kind of the do's, the don'ts, the goods, the bads, and then really open it up for an opportunity to discuss, ask your questions, and kind of interact real well here after lunch, keep us engaged. So some of you may have seen this slide. It's kind of the vision for quality measurement. And really kind of where we're headed is looking for new data sources to improve content flow, really kind of looking to see how can we push data to better reporting, and looking for better accountability across all levels. And so looking to see how do we move towards more electronic clinical data that can be passed along from providers to plans for reporting, and really look to minimize the more manual processes that go into collecting data and pulling data from different data sources to be used for reporting better measures for programs. Everybody's got more programs that you're accountable for reporting to. Everybody's got different requirements. So how can we kind of help to even the bar, making sure that measurement can be more accessible across multiple programs. So this here is a schematic that Ben Hamlin here at NCQA actually has developed, and we've all kind of used it and helped to show kind of where data are headed. Looking from the payer system on the far left-hand side, EMRs, case management, hospital records, pharmacy lab data. So these are all kind of your point of service systems. These are the data that you're accessing, you're collecting to be able to be used to kind of push into for reporting. You're going to transform it. You're going to get it from different applications. We've got the cell phone links. Everyone's got a mobile app with maybe their health plan that they're getting it from. That integrates with your membership data, your provider data, your facility index type data. How are we linking all of those sources together to push together, integrate into that knowledge center to then put out for quality reporting? And that data then goes to CMS, to NCQA, to your state Medicaid agencies, whoever it is that you're responsible for reporting. And really kind of where we're at here is that far left side. How do we get those data? How do we get them into formats that are usable and accessible, pass an audit process that can be used with very minimal translation and transformation to make it easier and more user-friendly? Some basic, couple of terms that everyone I think kind of gets confused, myself at times, has to be reminded in terms of what's the difference between ECQM, digital measures, ECDS. I know the work group that I was working with this morning really kind of wanted to focus on the ECDS, that far end. What does that mean? What are the definitions around it? How do we make it work? ECDS is a reporting method. So for those of you familiar with HEDIS reporting, we have administrative reporting, hybrid medical record reporting, and ECDS is another domain, another way in which to report measures considering electronic clinical data. ECQMs are electronic clinical quality measures primarily used for federal payment programs that are specified to be reported from a provider level to take into account just the provider rates, how they're performing. Digital measures are ECQMs that have been specified by NCQA for health plan reporting, taking into consideration the continuous enrollment, how the attribution works related to health plan reporting. So the ECQM digital measures are more how measures are specified and how they're written, and ECDS is a way in which measures are reported. It's a method to report them. So kind of helping to keep some of those things in line and straight. So as we've got the auditors up here, so for those of you that are, whether you're with a health plan, whether you're with a measure vendor, whether you're with an aggregator, wherever you're coming from, have been familiar with how data get passed or used for HEDIS reporting. So ECQMs, electronic data, clinical sources of that nature, EHRs, case management registries, currently for HEDIS reporting are considered supplemental data. So this schematic, it's probably a little small for those of you on the far side of the room, but what this schematic is showing are all of the data sources that are used and considered for HEDIS reporting. So from the left there with the box that the circles flow into it, that's your traditional transactional data. So your claims, your encounter, and then any type of vendor or ancillary provider data that flow into that. So pharmacy, lab, dental, behavioral health, they flow in and usually follow that traditional claims, encounter, data, flat file 837 that just process through. It's got your ICD-10, your CPT, very standard codes, don't usually need much in the way of having to interpret them. Across the top, we've got enrollment data. So for measures that are, to consider continuous enrollment, you would pull in those files so you can take into account that. And then along the lines of provider data. So if there needs to be a provider type, how do you identify that? Medical record data, so for hybrid measures that use both medical record and transactional data, looking at that data source. And then supplemental data. So this is that bucket of data that incorporates anything besides your traditional transactional data. So case management systems, laboratory result feeds, gaps in care databases that you might be collecting year-round, or year-round chart review that are not used for the actual medical record validation process. And then we've got the other square box off to the side are the ECDS data sources. And so there's really kind of an overlap between the ECDS or the clinical data sources that kind of overlap with supplemental data. Many of you are very familiar with the requirements for supplemental data and how do those then transition to be used for ECDS reporting or clinical reporting. All of those flow into that pentagon or plate looking, and that's our data pre-production processing. That's a new standard this year for HEDIS, for those of you that undergo a HEDIS audit. And what we're really looking at, and some of the auditors may touch on that as they are, I don't know what I'm doing, sorry about that, may touch on that as part of your audit process is really what are you as organizations doing to prepare your data? How are you having to map it? How are you having to link it between data sources? So once it goes through that, then it feeds out into the data integration and then ultimately into HEDIS reporting. So that supplemental data, the far kind of left side is right as you're looking at it, are really kind of where we're going to focus because that's kind of where that clinical data, the ECDS data that we're all here kind of talking about today. So I think, if we can move to the next slide. Oh, there it is. So supplemental data, as I kind of mentioned, it's data that are beyond just your transactional data, so your claims payment type data. These data for HEDIS, traditional HEDIS reporting can be used to identify your numerator events, optional exclusions, but you cannot use them to identify your eligible populations and your denominators. Those you should be using your traditional claims data. We categorize these as standard and non-standard. Standard data being those that come in as it implies a standard format, so standard dates, standard coding. It doesn't, so we were talking earlier this morning, that standard doesn't necessarily mean that it has to come in an HL7 or a CCD. It's just a standard file structure that has been defined, that is used over and over, that it's not changing every time you receive the data file, so that it can be validated and approved for use and it's not going to change. The non-standard supplemental data are those that really kind of they're not standard. They come in different formats. They may have to be mapped or cleaned up in order to be used. You are filling in gaps in care, so you're entering something into a database or pulling information out of a chart. Those require additional levels of validation. So those of you might be familiar with auditors asking for medical record documentation to support that in order to use it for audit. These all have to be audited annually. You have to fill out documentation to provide to your auditors to support those and undergo primary source verification for those non-standard sources. So what we're going to do, so that's real quick, high level, because I really want them to kind of talk about their experiences, because what we're here and kind of what the group that I'm leading with some coworkers are looking at how do we further specify the audit requirements for these clinical data sources that you all are trying to use and trying to capture to meet the audit requirements. So where do we need to adjust audit requirements? Where do we need to make sure that the data from the sources that they're coming with meet the needs of the measures, the specifications, and so kind of how can we come together and learn from one another? So for those of you, the ECDS measures for the first time for HEDIS 2019 have to be audited. So kind of what does that look like? What are the requirements? How do we make sure that everybody can be on the same page to pass the validation of those. And for those of you that provide data to the health plans, the payers, how do you make sure that the data that you're working so hard to collect and to format and to provide as a service are meeting those requirements and don't kind of get tossed back and say, sorry, it can't be used. So we really want to use this opportunity to hear from the auditors what they're seeing, and then hear from you guys. And then if anyone wants to join us this afternoon for some continued discussion, that's kind of what we're focusing on, is how can we kind of mirror the audit process along with kind of the increased use of these clinical data. So with that, it was kind of quick, but I'm going to turn it over to the panelists to start their discussions. Glenn, are you first? Oh, okay, I knew.
The first, second, third order was decided by the
Oh,
person
well, there
with the
we go.
microphone, so it's not like there is
The mic
any.
guy's in charge.
Exactly, he was in charge in deciding who goes first. Thank you, Wendy. My name is Anu Saja, and I have been a HEDIS auditor and a practice lead for 18 years now. And it's a challenge, and every year we do this, every year we feel like we are learning something new. And maybe that is the reason we are still continuing to do this. So with regard to ECDS, some of our plans were reporting ECDS measures for the past couple of years. But as Wendy said, 2019, if a plan chooses to report, it has to be audited. Therefore, a lot of questions are coming up. Based on what our experience, still for most of the plans, it seems to be like an unknown, and there is a lot of concern and fear of that unknown with ECDS measures. And what we are trying to tell plans is, it is true that this whole movement towards ECDS and digital measures, et cetera, is to make it easier for plans to measure and produce the rates that, performance measure rates. So the electronic clinical data, like the way there is a hierarchy, claim administrative data seems to be the last one. And first one is electronic health records. Second is health information exchange or registries. And third is case management data. Last one is administrative. Until 2018, it was called administrative claims, but now it is called administrative because you may be able to use, health plans are allowed to use enrollment data as part of the source system of record, which is nothing but the data source. You may be able to use state rosters that you receive if it is a Medicaid plan and various other sources that the technical specifications have mentioned. Several plans are trying to report ECDS measures so that they can get a heads up when more and more measures are moving towards it. The most common source appears to be the electronic health records at this point, and also some of the plans are using HIE, health information exchanges, depending on where they are and access to that data. Case management, at this point, I don't know whether plans need to look at case management as strictly the case managers, what they do at health plans. You may want to extend that. For example, if your health plan is administering health risk assessments in order to obtain more data about your members and better manage the members, you may want to consider that source as long as it is an electronic source and it meets the requirement and has all the required data elements pertaining to the measure that you are reporting. So I don't want to go through the entire process because there are, Matt and Glenn will also add to that. So those are some of our experiences at this point, and a lot of questions are coming up. One of the most important questions that plans are asking, what is meant by the data source should be available to the provider? Is it an electronic feed that the plans are expected to send, or what is the method? As far as I understand at this point, the technical specifications are not as prescriptive. The data sets should be available, any of the data sources that you are using to report electronic data, ECDS measures, should be available to providers who are providing care, the care team, upon request. And how you do it, right now it is up to the plan. If you can establish a process that this is our process, and you may want to share the same process with your providers. If you need this data, we have this process to share this data. That's what your auditors are going to ask you. So there is no prescribed method at this point that you need to have this in place. It has to be bidirectional and all. Right now it's not there. these measures are still evolving. So if we understand those aspects of it, it doesn't seem as bad as it sounds at the first go when we read the measures. So I'll stop and then hand it over to Matt and Glenn, and then we can take the questions later.
So I think the biggest point that I'd like to emphasize is that you shouldn't really worry too much about your HEDIS audit. Now, before Peggy throws her salad at me and Wendy throws me off the stage, I'm going to try to put that into context. So with all of this data that's coming into use now, right? We're getting data from EHRs, and meaningful use has really promoted an extraordinary expansion in this clinical data. So now in that setting, and then if you look at HIE and interoperability standards that are being promoted from ONC right now, I think you're going to see an even greater expansion, right? So in this setting, it made sense that the quality measurement paradigm would shift over towards something like this ECDS paradigm that we're looking at now. So in the new general guidelines this year, there's mention of a master data management concept. And this is something that's not new to most data managers out there, but is new to the audit. I'm a data guy, so when I read it, I did my little dork dance, and I was super excited. The primary concepts of this master data management philosophy, are what are you doing to ensure that your data is accurate, that it's complete, that they're complete. Are you doing validations on your file size, on what kind of content's in there? Are you ensuring that those security CIA principles, that the integrity, the accessibility? Are you going out to try to find data sources that address the gaps in your current data set? Are you looking at where you're underperforming and going after data in those types of places? And then on kind of a micro level, there's also the specific application of are you doing field validations to make sure that you've got the right data type? Are you deduplicating? Are you doing all these very, very granular checks to make sure that you're not allowing in a blood pressure of 1300, which mine may be pretty close right now, but you don't want to let that kind of stuff into your data warehouse. So, the data management principle, I think, is really important and extremely valuable that it was introduced into the audit. So, secondary to that data management, which probably most organizations have, they may not call it an MDM program. It may just be, these are what we institute in our policies, in our procedures, in our standard operating procedures. The important thing with regard to the audit is effective communication, openness, right? So the method that the plan uses to communicate their systems, their policies, their procedures, is sharing the roadmap. So sort of the regular way that that's done is, for items that come from within the organization or their department for that fills out the roadmap to communicate that picture to the auditor. And it's very important that it's complete and that it paints an accurate picture of your systems, right? So in cases where it may be a vendor that's fulfilling this particular service, often a vendor will produce that roadmap section and then the plan just kind of passes it on. Well, the vendor likely has all kinds of stuff in there that are services you may or may not prescribe to. They may not apply. Your implementation may be specific. Your implementation may require a lot more context for us to understand how you ensure quality and how you manage that interaction. So it's important that you work with your vendor and ultimately take responsibility for that roadmap section and how the plan, that your auditor can really see that it's full and accurate. That's it's a fine line because there's a case where you give too much information. If you send, an attachment 5.3 that's 100 pages, you may not get very good coverage on that. But if you send too little information, you run the risk of being miscategorized as non-standard and being held up to a higher standard of validation. So it's really important to be succinct and really full in your, in your presentation of your systems. So with regard to the ECDS sort of paradigm, I think it's important that this agnosticism about the data source is being introduced, so that what we're really trying to assess is, okay, well, what is the data source saying this event was? The data source says that there was a clinical event, and we want to validate that that's accurate, right? So the difference between supplemental data or any other data type for that matter, claims, whatever it is basically that communicability that Anu was talking about, so the care team can get access to that information, and then the ability to flag it as one of the hierarchical data types, right? So it's it's coming from EHR or HIE or whatever. So in that setting, I'll try not to go over my time, but I think I think it's important to realize that you as an organization are not, your purpose is not to have a good HEDIS audit. And there's like 5 people in this room whose purpose it is to have a good HEDIS audit, and most of us are on stage. Your purpose is to take care of patients and to have streamlined and efficient operations. So when I say don't be too concerned with your HEDIS audit, if you start with those first principles, you start with taking good clinical care, and you operate efficiently, you have a good data management practice, and then you communicate it effectively with your auditor, then you end up having a smooth HEDIS audit. It's secondary to all the other stuff that you're supposed to do to set that up.
So I guess that means it's my turn. I'm Glenn. I've been HEDIS auditor for 11 years, something like that. So I'm working with data many, 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 many years, back to the days when Prudential Healthcare existed. And I was going to talk a little bit about problems we've seen with these things to sort of be aware of. I know we spent a fair amount of time in the group that I was with this morning talking about data quality and what's in there, what do you get, how do you get it, how do you make sure it's right. I mean, I think we're all struggling, and I think a lot of what we're talking about here is struggling with EHR data, because we have, it's supposed to be standard, it's supposed to be meaningful use, but we all know it's not standard. We all know you've seen one EMR, you've seen one EMR. Apple worked with those 5 or 6 groups, because I'm sure every single one of those EMRs were very different, and they had to figure out how to map each one separately because nothing was consistent. They couldn't get a feed. And we're getting all of these feeds and mapping from you because you're having to deal with mapping from 100 different sources or 1,000 different sources, because it isn't standard. There's nothing standard about an EHR when you get data. I've seen too many. And I'll have an example. So I think, I'll start with the example. So when I'm looking at supplemental data or ECDS data or any kind of data, one of the first things I'm going to ask is, how did you ask for this? What did you ask for? Because what you ask for does impact what you're going to get. I have a health plan. I don't think they're here. who asked for a data dump from their gastroenterology group. They had like their largest gastro group. They asked for a data dump because they were looking for colonoscopy and colon cancer screening. So they gave them a data dump. Okay, let me see it. So they had this dump. All right, I want to look at some of this. And I think I picked, well, I don't know how many I picked. I only had to look at 10 records, because I started looking at these records, and I want screen prints from the system or wherever they pulled this out, so I know their data dump, what they dumped to you. And I think 6 records out of the 10 were either patient refused, I referred them for a colonoscopy. One of them was I confirmed that the person was compliant for colonoscopy because they had a colonoscopy back in 2010 or something, and they put in the date they confirmed it as the date of the colonoscopy. So it was, way in the past, but okay, they're compliant. No, that's not what the field said. And okay, you have to chunk the source because it's not based on, you didn't ask them for completed services, which may have helped, may not. You asked them for a data dump, and they gave you a data dump. And so I think one of the places that I like to start with this is, what did you ask for? If it's a aggregator, what did they start with? What is their process for asking for this data? Did you ask for completed services? I want to know that these services were actually done. If you're going to get graded on it, you're going to grade yourself, you're going to grade some of your providers, CMS is going to grade you. I want to know it actually happened. It doesn't count that they referred, the patient refused. I have the most non-compliant parents on the planet. I've talked to my mother I don't know how many times. No, I'm not doing that test. Don't care. I'm not doing that. Okay, I'm telling you, you should do this. Doesn't matter. So it only counts if it actually happened, and that's sort of the basis for where I want to start with looking at the mapping and does it make sense. And then I think we put a lot of emphasis on was the map, where did the data start from, how was it pulled, where did it go, how did it end up, what did the next person do with it, and how did it go down the line? Because each of those handoffs can do things to that data. And I get real nervous, I start getting hives, the hair on my back of my neck stands up when I'm on a conference call or a thing where a vendor's telling me or telling the plan, and they're telling me either through the plan or themselves, this is what we do, and we do value add, we data dig, we data enhance, we transform, we scrub, we have artificial intelligence to figure out what did this happen. I'm like, okay, I'm going to want to look to see how intelligent was this artificial intelligence. Because I really don't know. Did the patient, is it in the notes that said the patient denied their colonoscopy? Well, that doesn't count. I can't let you use that. So I don't know where I'm going. We're all dealing with very unstandard data. I don't know how else to call it, because it's in these systems captured in different ways. We had an example this morning where someone sent their SNOMED codes for colonoscopies, and when they tested it, a huge amount of the tests were from people denying or refusing that they were not going to have a colonoscopy. And the way that the EMR worked is they clicked the button that said colonoscopy, they clicked the button, they put a note, patient refuses, but because they clicked the button, that made, when it fed, the SNOMED code come out that they had one. So we're all given this challenge of the data, and how the clinician uses it impacts how it comes out. And for me, the gold standard is, what's your QA process, health plans? I'm going to ask, because I can't QA all of your data. There's no way I don't have time in my lifetime to QA all of these data sources. I just can't do it. So what is your process? That's my second question. First is, what did you ask for? And then how did you QA it? How do you know, do you have any confidence that this data is actually what you asked for? What did you do? Did you do anything? And did you get screen prints to say, yes, the data that they sent me matched the screen print in the system, like a sample? You don't have to do hundreds. Did you do a sample? Did you look at anything to say, yep, they told me this happened. I looked at the screen print from what the EMR shows, and that's what happened. I'm confident that this is correct, and this actually happened, and it was a completed service. And that makes me feel much better, and I don't need to dig as deep. If we asked for a data dump. Oh no, another one. I'm going to disappoint you and everyone else, because I'm going to say you can't use this when I dig into it. I guess if you want to add anything, or
Wendy?
No, go
Questions?
ahead. I mean, you guys can, or we can open it up to question.
But I really liked your comment with regard to AI, and that I think ultimately when we're looking at EHRs, like Glenn said, we see these C comments like crazy, right? And these C comments either one, the C comment is what's being brought in on your data file. Well, the measure is not going to give you credit for a C comment. You need a result. But like he said, a good amount of the time, it's actually saying, oh, well, this procedure was never done. So that's another big problem. So, the long-term solution may actually end up being a machine learning AI sort of implementation to be able to parse the full record, bring that information in, because there is a ton of information out there that's not being, it's not being moved into CCD. It can only be, at this point, really gotten from PSV, or from POS documents, right? So you've got your clinical nurses, you're going in and doing manual review. Now, in this setting of moving to this new electronic paradigm, lots of medical record review nurses are saying, I'm going to lose my job. So you're not going to lose your job. One, that AI module doesn't work without somebody teaching it how to work. Two, it will always be reliant on PSV. If you aren't doing it internally, then you're not going to pass it externally. And it's really something that's extremely valuable in your data management process. You have to maintain that strong cadre of clinical staff that can validate and verify that your data is what it says it is. And you have to implement that internally if you want to be successful going into it. And then, with a lot of these initiatives, the other point I wanted to make was that you can't wait. Don't wait before you start investing in these processes, before you start investing in some of these, gathering these data sources and starting to look at AI or talk to companies and see what they're doing and find out best practices. At the very least, you have to start your research now in preparation for your implementation when it gets down to the nitty-gritty. But yeah, you can't wait any longer.
So before we go to questions, which may help a lot because several of you may have questions, just few points. We are encouraging plans to report ECDS measures. Right now, they are not publicly reported. They're not used for accreditation. You might as well take this opportunity to try to report these measures. If you really thoroughly understand, take the fear out and then look at the measure. It's not as complicated as it appears to be. Pretty much more or less all plans have some data source or the other that you can report at least one or two measures. And you can try if it is immunization measure, if the registry has adult immunization data, if you have case management system, if you have PHQ-9 data, or you have administrative data sources which you may want to. The key is working with your legal and working with your operational people to see how, if the care team requests for the data, what process do you have to send that data to the provider? And also, if you have a data source, rather than thinking, yeah, this will not pass ECDS, maybe you need to work with your auditor to see, I have this data source, can we use it for this measure? Your auditors will be a very good source for you to answer those questions. And you may want to explore the possibility as NCQA is moving more and more towards ECDS measures and digital measures. You want to take the opportunity that you have to report those measures when they are not yet publicly reported. Otherwise, you may be one step behind as compared to other plans who are taking the plunge and trying to report these measures. So that should help you a lot. And you have NCQA to answer your questions through PCS. If you don't want to go that route, you can ask your auditors. But it seems like a possibility now if you understand the measures. And someone else asked in the breakout session, is there any data source that will say, oh, you can't pass ECDS at all? I don't think there is any such things. If you read the requirements, try to use the data sources that you have and talk to your auditor. It's highly likely that you will report at least one or two ECDS measures at this point.
So do you guys have questions for these auditors, for NCQA? There's Mike here. Mike here.
Hi, Dave Grinberg from Imprado. Other than the low-hanging fruit of getting the ambulatory providers connected, what do you see as the biggest challenges to HIE playing a meaningful role in improving the quality reporting?
Following the path of the data, that the HIE entities don't seem to take any responsibility. Is that data correct at all? So they just take it in, it comes in, they store it, and then they'll give it out. So how do I know anything in it is accurate? Who mapped it? Has anyone checked to see if anything in it is accurate? Because I can't get anyone to take responsibility to tell me they did.
Yeah.
So data provenance and governance.
Data quality,
Right. And
accuracy, and precision.
yeah, and come up with creative ways to validate that at least there's a good possibility that those data are correct. If you can reconcile with versus claims or whatever sort of initiatives that you can do to sort of look at that and see, okay, well, is this feasible? Is it possible that this event occurred? A real big key with the HIEs is member identification, because they've got such an extraordinary volume of data coming in. You've got to be able to very accurately identify your membership. You can't just use John Smith with a date of birth, because they've probably got 50 of them. So that's a really important one with the HIEs. And because we have a hard time getting the primary source documents for those, it makes it much more critical that the administrative policies and procedures surrounding that and the data provenance are well established and communicated. The provenance is huge.
HIEs were also started. One is to connect all the ambulatory care providers, but there are so many other benefits through it, reduce overuse and sharing of data, sharing of information. So not just to look at some of the states that at least I was at and before, and they were really encouraging providers to connect to HIEs so that they can reduce overuse. They can see if the service was already provided. So it's not just for reporting purposes for health plans. It can benefit in so many different other ways also. It can be the conduit for sharing data with all parties involved in not just this provider providing data and health plan receiving the claim, but other providers who are involved in the care of that member.
Thank you.
Okay.
Hello, John DeMore from Diamond Health for this. So one of the slides that Wendy showed earlier was about standard supplemental data and what falls into that category. EHR data, lab feed data, and also now eMeasure certified products, so technology that's certified by the NCQA. I'd like to get thoughts, perspectives on that. That's new in the last several years for it. And what role do you see NCQA playing with what you were partly talking about with cleaning up data in data quality and dealing with what we get out of EHRs, which is today not standard or not the same across many different instances?
So that's a really good question. I was hoping somebody would bring up eMeasures. So there's a lot of questions surrounding that right now because historically there's been minimal adoption besides your organization. So the question is for us, what data are you getting from that eMeasure? So now we've got the published guidance that it can be standard, but are you getting a QRDA1 granular file, for each patient? If you're getting that, can you parse the QDM segment to actually extrapolate meaningful clinical data? Or are you just does the certification really matter? We've got very limited measure sets with the QRDA1 actually certified. In most cases, it's the QRDA3. So the QRDA3, if you don't know, is basically just it's that summary. And it has no HEDIS value because you have no granular results. You can't really do anything with it. So it's really important, I think, to look at the organizational capabilities. It's easy to say that we can get some value out of this eMeasure data, but it's going to take a little bit more than just getting. You're not going to just get a flat file. You have to learn to parse it. You have to learn to how to use that data, how to collect it. And then, I think that there's still a little bit of ambiguity concerning the certification requirements, but I think as a community, leaning towards, the sort of the format, the QRDA, being a high integrity format. And so, treating that pretty much standard, whether or not it's certified, if we see that the data management is there. If it's at a high level and we can validate it.
And I think from a data quality standpoint, because a lot of this is very difficult because it's not standard. You can't pull things out. It really goes back to NCQA working at the highest levels with CMS, the AMA, to really, from the owners who drive EHRs and drive the data and the standardization of data in the systems so they can be used, because there's all these complaints, it's an overwhelming burden, there's so much to do, and unfortunately, you can standardize the measures so that they're consistent across, but as long as the data that the source you're starting with is not consistent, the source is 100 different cats running in 100 different ways, and you want to pull it out, but you can't because it's just not there. Some people's idea of an EMR is scan a picture of the vitals that the nurse wrote down into the EMR. Well, that's not going anywhere because it's a picture. So until the powers that be, NCQA, CMS, AMA, they have to get together and say, we want to reduce this burden, and one of the ways to do that is the EMRs have to be more consistent with what's in there and what can be taken out. And until that happens, we're going to be sitting here talking about data quality forever.
So while we are waiting for the whole world to change, to go to where Glenn and Matt just explained, from an operational perspective, if data aggregators are essentially getting certified for e-measures and you are getting data from various sources, if a health plan wants to use that data, in order to pass the audit, if it is e-measure certified and it should be standard, so the auditor will ask basic questions. What are all the sources from which the data aggregator obtained this? If you have 27 different sources, which is fine, auditors want to make sure that you have an understanding to explain. One of the data aggregators that I was talking to when a health plan wanted to use their data was, that's why I came up with 27. They could not explain 9 sources how the data came to the aggregator. So they had an option, either you can subset that and not to use that, or use the data that you can explain, and we can vouch for, at least to some extent, that we have an understanding of the data flow from the beginning to the end, how it came to the data aggregator and how the data was sent to. So if that flow can be explained properly and correctly, and it's very clear with all the balances and checks that you have, and you have documented quality checks and everything else to show the integrity of that data, that should meet the requirement of the audit at this point for e-measures, data coming from data aggregators or e-measure certified vendors, et cetera. That's how I would look at it.
Hi, Terry Kitchen, Healthcare Service Corporation. So mine is more around the burden of the audit. So we have been adding supplemental data sources, like going through the roof, and we audit them ourselves. We always do 2 audits a year on them. So we've got to handle it, but it's getting more and more and more. And I actually am worried a little bit about the audit cycle and how small that window is to do all of the verification of all those sources. And so not only the cost of the data, because that's going through the roof, but then there's the work that you all do on each one of those sources and the compressed time period. I'm wondering how, if we're continuing to add and add and add, and the financial burden of doing all that auditing is quite high, where are we going to go? Like, how are we going to fix this?
Part of the answer, I think, is to figure out how to be more efficient. And I think talking about collection of EHRs and to think of the health plan more as a aggregator. This is our standard process to aggregate this data from all of these EHR systems. Maybe you have multiple processes, but this is the process that these 10 went through. And this is how we asked for this data. This is how we QA'd this data. So it's really, you're like an aggregator. This is the process. And the auditor could look at a sample of the mapping, but they don't look at every mapping because it follows a standard process to get that in, as much like the aggregators do. Much like it's the process that gets validated, not each individual EHR. Because I think we have to come up with. I think we have to get more efficient at how we evaluate some of this.
Yeah, and
From an audit standpoint, because
go ahead.
can't do it all.
So, I think we're at that sort of painful transition point before we hit economies of scale. And so sort of the interim strategies that may be most effective are, determining what sources you're getting the best lift from. And if your return on investment for a source, if it's costing you a ridiculous amount of either effort or money, they're synonymous, but it's not giving you a whole lot of impact, you need to assess whether or not it's worth it. The long game is that ultimately we get to the economy of scale, where HIE reaches a stage of maturity where it's reliable, and we get to a level of interoperability within the field where we can really start to take advantage of some of these gains, both from an efficiency and from a completeness and accuracy standpoint. I think we're in that painful point before the long game really pays off. But you have to. I think in the meantime, you just have to be judicious about what you're willing to expend resources on.
We had an example. I had an example with one of the plans. They were using 65 different supplemental data sources. If you think about the burden on the plan, think about the burden on the auditors. That's why we look like this. We barely have any sleep during the audit season.
I was actually thinking about that. How are you guys going to look at all that?
It's just, 16-hour days, 7 days
really
a
quickly.
week and all that. Yeah. So what we suggested to that health plan is look at the data, analyze your supplemental data sources. What is the yield? There is so much duplicacy. There is so much redundancy. You are building all these supplemental data sources, you are receiving all this. Maybe you are receiving one data point for one member, a numerator hit from 9 different data sources. So try to analyze this data, understanding very thoroughly each supplemental data source, what is yielding more and where is lot of duplicacy so that I can reduce this. I will rely more on the ones that are giving me better yield. And if there is you spend so much money, resources, and time on one supplemental data, and the impact report shows that the impact is 0.0001%. I would ask, am I doing this if I were the health plan where I came from health plan, so I understand. Am I doing this? Is it worth it for me to do? Can I reduce my supplemental data sources and put my money and resources and time on those, which is yielding me better results, and focus more on those, and also rely more on standard supplemental data sources, reduce dependency on non-standard supplemental data sources.
And I think from the NCQA side, as we work with the auditors and all of you and kind of learn, that's kind of what we're here for today, right? So we want to see a more push towards that standard data, the more push towards clinical data feeds with standard codes. We're working to expand our value sets for the HEDIS measures so that more codes apply and count for measure compliance rather than all that additional mapping that you're currently have to do, the auditors, and have to validate. So while we know that data sources are growing, the more standard we can get them, the more uniform, more consistent, that minimizes the extra need too. And you mentioned timing of the audit. We've been asked, the audit process right now is pretty prescriptive in terms of when data can start to be validated. And there's been questions around, can some of these supplemental data sources be approved sooner? So those are things that we're looking at and talking about, and what are the implications of that? What does that mean in terms of good, bad? How does that affect the audit? So we do hear that if we could take a look at these sooner, that we're, a lot of your auditors look at things all the time. Are we on the right path? Are we heading down here so that when it comes time to audit it in March and April, it's easier to get there, or you've not found out at that point that it's too late? So how can we maybe expand some of the timing of looking at supplemental data sooner and adding a stamp of approval to then minimize the push during that crunch period?
In other words, take away our sleep even during the non-season. That's what it is going to result, in.
What non-season?
Really.
Hi, you guys look fine, by the way. I think you should sell yourself so short.
You can't see the bags.
My name is Ross Martin. I'm with 360 Degree Insights consulting firm, and about half my time is at CRISP, the Health Information Exchange for Maryland and DC and West Virginia. I just wanted to return back to the HIE comments you've made to make sure I heard you right, because you said kind of 3 responsibilities of the HIE. One was about the data mapping, which I kind of get, that we want to, if we're getting data in, we want to put it in the right spots so that when we send it to you, you can get it in the format that you're supposed to have it. One was provenance, which I can certainly understand why that would be important. And then I think you said veracity, like we have to be able to prove that the data we're receiving is actually what happened. And
Someone does.
well,
Whether-
yeah,
whether it's
I
the
believe
user-
somebody does, but I don't know how, coming from thinking about what our role has been, we are not trying to tell, we are not trying to be a source of authority about clinical moments or clinical data in any way other than this is what was reported to us, and we're trying as best as possible to accurately reflect what was reported to us.
And that's the concern and the challenge with using it for HEDIS, because we have no idea what those providers have sent you. You don't have any idea that they pulled it correctly. You don't know if they're sending referrals. You don't know if they're sending denials.
Right. But it does feel
claims have a process, because if a provider submits a claim to Medicare or to a health plan and it's fraudulent because it didn't happen, they're accountable and they'd be in trouble. Right now, there is zero accountability if they submit inaccurate quality data to an HIE or to a health plan. If they said, I did this, you asked me for what I did, and they send all the denials to you or patient refuses as it happened, there's no accountability for that. They don't get in trouble. If it goes through, they get a bonus. Woo! So somebody, whether it is the HIE, which I would love if that's who took responsibility for it, or the health plan, whoever someone's got to take responsibility that it's accurate, completed services.
Yeah, that's where you lost me.
Because the money,
I do agree
the
importance of that, but I think the provenance part is where the HIU's responsibility to say, well, the data came from here. They are responsible for not committing fraud and sending us stuff that's not correct. Obviously,
the
trying
responsibility
to
is on the
understand
plan to go back and make sure to audit the data to see that it actually happened, which is usually too much for plan to do.
The intent may not be to commit fraud.
Yeah.
The intent may be the lack of clarity in the instructions that were provided to the provider groups who are sending data to HIE. So there has to be a very clear instruction. That the problems that we see sometimes, I'm not talking about HIE, otherwise in provider portals and all that, colonoscopy ordered versus colonoscopy conducted, a lab test ordered versus lab test done.
Right.
So the instructions, the field definitions, etc., have to be very clear in what is being asked to send. Those are I would consider that as a small proxy to figure out, are the instructions very clear what data is coming into HIE? So we look at data dictionaries and data field definitions and all that. Those will help us to figure out the integrity of the data rather than throwing out the entire data set.
This sounds like a much larger conversation, which we don't want to perhaps have here, but the last comment I would just say is, I consider CRISP to be a fairly sophisticated HIE among them. We are in no way in a place to do that kind of work at this point, and so I don't see that coming soon.
I would argue in support of your position that you are not, nor should you be, responsible for the veracity of the data.
But I think you should be eventually. That's where we need to move to. That whoever's holding it is responsible for the veracity of the data they hold and share.
No, I think you should be held responsible for the practices, the governance, and the movement of those data. And if you have those solid data management practices, then you've done your part. But ultimately, it's the source and the plan that are responsible for making sure that it is what it says it is. So you've got to go back to people that can affect change. You can't affect change upon what the clinician is documenting as an HIE, but the plan has a responsibility for somehow validating it. And so, there's a lot of unanswered questions in there. There's no doubt.
Next question.
Great. I've never been in such a fun panel session.
I'm glad you're enjoying.
It's almost like this is like my office any given day. I appreciate your comments. At Montefiore, what we've learned to do. So one gap that we've noticed is that each health plan has their own set of crazy process, right? So for me is so we have a process where we map the data, and we have an EDW, and we have encountered it. We tend to stay away from supplemental data for all the reasons you've addressed, right? So we make sure it's encountered. If I don't trust the data enough to engage a patient based on that data, then I don't submit it, right? That's like the standard rule.
That's good. That's wonderful.
And I don't want my providers to think, to Matthew's point, about whether they're passing an audit or not. What we do is we use audit results and your QA process to integrate it as part of their provider education, so that they know from the beginning, they're already doing what they need to do as clinicians and doctors. They need to focus just on, the system should focus on appropriate documentation. That's the second thing. The third piece is we do have a data exchange program with each of our payers, right? And in order for us to have a value-based arrangement with them, one of the primary requirements is that they support our data exchange process. We don't partner with payers that are unable to use the encounter data process on a quarterly basis, because we use that data not just for performance. That's like the end goal, obviously accurate performance, that's great, but the patient comes first. I want to use that data to engage the patients who actually have true gaps in care, and that should be the focus. So if we all focus on like being patient-centered in the way that we look at data, then a lot of our decisions kind of drive in the right focus area. And then lastly, we base incentives, and you raised this point, we base incentives on claims-based performance, not encounter data plus claims. The reason why is because eventually what I want to see is that clinical matches claims, right? So although once we share the final performance with a doctor and we tell them, look, this is your claims-based final performance, we give them 30 days to correct me, right? So if I miss something, which I should have captured before sometime during the year, then challenge me and provide me with supporting documentation then, versus incentivizing them for supplementing data. Because I should be seeing, part of the team's effort is to educate them on both coding and clinical. And both should be systematic. Shouldn't be, the providers are not billers, right? So they shouldn't expect them to do that piece. So I think lesson learned is incentivize for the right reasons and making sure that really the end customer is the patient.
That's good.
Absolutely.
Agreed.
2 minutes, okay. This will be our last, we have 2 minutes. So.
Oh, thank you. So I'm Zahid Bhatt with Medisolve. We implement a lot of ECQMs, both hospital and ambulatory, and have a lot of experience in the data extraction and the use in the ECQMs. I think one of the sort of missing pieces often, and it may reflect some of the examples that you were giving, is not as much potentially fraud or inaccurate data, but it's missing attributes of the data types. And that creates, you lose the context if you don't have that, and it's not that easily decipherable from the way it's stored in the EHR. So we spend a lot of time trying to figure that one out. And once you get that figured out, then your data begins to look more accurate. Not perfect, but certainly looks more accurate. So just wanted to make that comment.
That's good. Thank you.